Well, good morning. I am Wayne Tuckson. I'm a retired colon and rectal surgeon. I have the pleasure of being the moderator for this program. As you will soon see, we'll be hearing from some very knowledgeable speakers, but we also want to hear from you. So if you have any questions or need of clarification, please raise your hand and I will get to you so we can answer those questions. Our goal today is to inform those of you who have small cell lung cancer and those who know someone with this disease that hope is possible with early diagnosis, treatment, and support. We will further show that this hope will be made incarnate by ensuring access for all to treatment advances in small cell lung cancer, but only if we all do our parts. Today's program is hosted by Lilydale First Baptist Church, Legacy Campus here in Park Forest, Illinois, with the Reverend Dr. Alvin Love as the senior pastor. The HEAL Collaborative, a nonprofit organization out of Atlanta that focuses on health education advocacy, learning to improve the health of our community, and Amgen Inc., one of the largest biotechnology corporations in the world and headquarters in Thousand Oaks, California. Representatives, we have several representatives around from HEAL, including Gabriel Jones, who's at the desk, who's the Vice President for Community Engagement and Advocacy, Mr. Justin Williams, who's Director of the Youth Engagement, Community Outreach and Advocacy Engagement, Ms. Shayla White, who's in the back, is the Director of Digital Marketing. From Amgen, we have Ms. Marie Watson, Ms. Liz Bajima, Anna Marie Donaldson, and later we'll hear from Dr. Diana Goto. We will now have our welcoming and opening prayer by Reverend Dr. Love, who's the senior pastor at Lilydale First Baptist Church, followed by remarks from the Honorable Howard Mosby, who is the corporate treasurer, HEAL Collaborative. Dr. Love.
Thank you, Dr. Hudson. Just let me say to each of you this morning, welcome. Welcome to Lilydale First Baptist Church. We are affectionately known across the city, Chicago, as God's friendly church. So we hope that you will find us accurately reflecting that nickname. We want you to feel comfortable, to feel at home, and we certainly want to thank HEAL Collaborative for coming to Chicago with such a great workshop and information that will make the lives of our community better. And so I just want to encourage you to have open hearts, open minds, open ears, and let those who will present today help us to become more aware of our surroundings and of our own bodies so that we can care for our neighbors. That's a biblical principle. We are our neighbors keepers. So to Amgen, to HEAL, to all of you who are gathered today, welcome to Lilydale First Baptist and welcome to this great conference.
Prayer.
Let's be having a preaching.
Even worse when I remind you.
Let's pray. God, we love you today. We praise you. We thank you for giving us this beautiful day that we can gather together in this sacred space to hear from you. We know that you will speak to us through those that you have selected today to give us information and insight into those challenges that many of us may face or our family members may face. We pray that you will arm us with information today that we might be better equipped to serve one another. We ask your blessings upon our gathering today. We pray that you would bless all of our presenters. We pray a special blessing upon HEAL and upon Amgen, that they would continue to do the collaborative work that will raise a standard of health care in our communities. We pray for your guidance today, all that we will say and do. It's in the name of Jesus we ask it all. Amen.
Amen. Thank you. You're off the hook now. I would like to remind you that if you have not done so already, please fill out the pre-surveys, and because at the end we're going to have you fill out also the back. Next is the Honorable Mr. Howard Mosby.
Good morning. Is it great to see you all? Good morning. Good morning. It's great to see all of you all this morning. It is indeed my honor as one of the board members for Hill Collaborative to say thank you. To say thank you very much, Reverend Love, for opening up your doors and letting us come into your house and put on this fantastic program. You're going to hear today from some awesome experts, some patients, and community advocates on how we can improve our community. And we are wanting to bring these educational programs so that we really change the status of health of our communities. And so it is indeed our honor and our pleasure to be here today. Now, my job is to bring up you.
Yeah, man.
Okay, so ladies and gentlemen, put your hands together for my good friend, Dr. Wayne Tuckson. He's out of Kentucky, but don't hold that against him.
Yes, please don't hold that against me. The next part of our program is something which is an informal sharing of personal journeys that we call the fireside chat. If you imagine sitting around our imaginary fire, we're going to have a discussion about what it is to be a patient and or to experience small cell lung cancer. We have as members who will be sitting around our fire. First, we'll have Reverend Dr. Alvin Love. I'll come up, take a seat. Next would be Ms. Montessa Lee, who is a small cell lung cancer patient, survivor, and advocate. Ms. Lalisha Payne, who is also a small cell lung cancer patient and advocate. And then finally, our moderator, Mr. Nate Stevens, who is also a physician's assistant, but he's the Senior Manager of Enterprise, Health Equity, and Advocacy Relations, Corporate Affairs at Amgen. Welcome to you all.
It is a fireside chat, so if we imagine there's a fire there, just please let's not make the conversation get too heated. We'll just keep it nice and warm. But I first also want to thank Reverend Love and the church for opening their doors here for us today. I think we're going to have a great conversation and educate folks on small cell lung cancer, but also the journey that these folks have been on. So first, though, I want to start with you, Reverend Love, if the mic is up and working yet.
Yeah, working.
I guess I'm just wondering, with the folks that we have here today in this program, I'll pass the mic over to you here in just a second. I'm just wondering if you could let us all know what motivated you to have a program like this in the first place.
Thank you, Nate. I am, and I've shared this, my church knows, I am a double cancer survivor. I don't say two-time, but a double cancer. I had two cancers at the same time, kidney cancer, and then I had a rare form of urethral cancer that the doctor said that I was the 12th person on the planet ever documented to have it, and they had no standard of care for me. And so here I am 8 years later, because someone decided to, take advantage of some of the cutting edge research. And so I believe that that we save lives of the people around us by making them aware of what's available. The Bible says my people perish for lack of knowledge. And when they don't know that there are ways to treat whatever challenge that they're going through health-wise, I think as a pastor, it's my responsibility. And even as a cancer survivor, I don't think that God let me get through it just to, keep it to myself, but to share it with someone else so that they know that they too can survive and thrive post-cancer.
Yeah, you make a great point there, and speaking to kind of sharing the message, so to speak. But I think that there's a little bit of an elephant in the room a lot of times when we're speaking to folks in the Black community around even interacting with the medical community. There is often a lot of hesitancy, skepticism, and in many cases rightfully so. So I'm wondering from your perspective, in addition to sharing your story, what are some things that you might either say or encourage folks in the audience to think about for their own health?
Well, one of the things that even from experience that I found out is that you need not be afraid of the research and being a part of the research, because we are underrepresented in most medical research. And so when they come up with vaccines, or they come up with medications or treatment plans, they generally follow the dominant culture because not enough of us have been a part of it. When going through the kidney issue, and I'm always checking my blood just to make certain that everything is fine, but I always get two different readings. One that says your GFR is here, all right, but then there's another line underneath it says if you're an African American, take this number. All right, so we need to be involved, I think, in the research process so that those who are making the drugs or making the treatment plans have access to more information so that they can better treat us. As I said, my oncologist came into the room to me and said, just shook her head, a bad bedside manner, but she shook her head and said, we have no standard of care for you. And because I said, well, you do the best you can, and I'll talk to my boss, we'll see what happens. But I had another young oncologist who had just come out of medical school, and he said, I want to try this. And it worked. It worked. And so when the professionals say we have no standard of care, but someone who has more information in terms of the research and on the cutting edge of it comes in, a life was saved. And I think we can save more lives if we take part in some of the research that's going on around us.
Yeah, no, that's a good point. I think speaking of that standard of care approach or lack thereof, we're joined here by 2 small cell lung cancer patients. And Montessa, I want to turn to you first. I think when we are thinking about small cell lung cancer, a lot of folks in the room might not even realize that there are different types of lung cancer. So if you don't mind, share a little bit about your story, and we'll talk more in just a minute about with Dr. Flanneau about what small cell cancer is. But tell us a little bit about your journey and how that maybe has similarities or differences from the Reverend.
Sure. So in 2006, when I was 28 years old, after 2 misdiagnoses, they never gave me an x-ray. The first doctor said, oh, you have costochondritis, which is inflammation around the rib cage, and possibly bronchitis. First it was costochondritis, inflammation around the rib cage. Went to another doctor because I still had a cough that wouldn't go away. I thought I developed asthma late in life. And they said, no, you're bronchitis, and a whopping heart murmur. No one had ever told me this, at the age of 28. So I was like, oh, okay. That December, so the September was the first visit to the doctor. December, the first week in December, I was driving to my grad school class. I lived with my cousin at the time, had stabbing chest pain, and I said, you have to take me to the ER. The pain came back when I get home. And I almost didn't go because the pain subsided a little bit, but I thought about it and I said to them, give me something for the pain, let's just go. That's the first time they gave me an x-ray. Mm-hmm. And I described what I saw in the x-ray to people as imagine you're looking up at the night sky with some binoculars and somebody takes a tissue paper and they cover one of those lenses. They ball up the tissue paper and you could only see 1/4 of that lens. That's what my lung looked like to me. Mm. So it would end up being a 15 by 11 by 9 centimeter mass, and inevitably it would end up being a diagnosis of small cell lung cancer. The way my oncologist described it, he said, hey, it used to be a stupid name. They used to call it out cell cancer because the way it looked under the microscope. And I laughed, like, yeah, that ain't a dumb name. Yet to know when I went to Google Doctor to understand the veracity and the disparities amongst lung cancer and it being the biggest cancer killer, and yet the needle hadn't been in research. And so I turned my anger to advocacy.
I think in some ways your story is similar to our next guest here, Miss Lalisha Payne. In some ways it differs. Lalisha, I think if you don't mind, share a little bit about your story and, the journey that you've been on so far.
Sure. First of all, I would like to say thank you for the opportunity to share my story. This is the first opportunity that I have been given to share my story with my people. So I sincerely appreciate that. My name is Felicia Payne. I am a retired social worker of 30 years. While in college, my mother died when I was 19 years old. Prior to that, I was an athlete. I had nowhere to turn, nobody to turn to. I turned to nicotine. And nicotine at that time was what I thought that I needed. It wasn't just nicotine. I also had a trust and a faith in God. Okay? But there was no one there to tell me all the things that could possibly happen. So a couple years ago, I went to the doctor because I was having some issues with my stomach. So I go to the emergency room and they say, we see a nodule on your lung that is becoming concerning. So I called my pulmonary doctor of over 10 years and I went in. And I can remember this thing like it was yesterday because he showed me that nodule. I was a little impatient at that point in time. And I remember how he raised his voice at me. He said, do you want to see it or not? And I thought, you know what? Just let me be compliant at this point because I know where I'm at and I know who I'm speaking to. So we looked at it. I took a PET scan, and on that PET scan actually showed that there was some activity in my lungs. He gives me a call and he says, well, I don't think I could do a biopsy yet because it's too small. Let me talk to the radiologist again. So he called me back and he tells me that we're going to have to wait 3 days before we look at this again to see if it has grown. Well, because I had an encounter with him before where I had COVID and he had denied me the antibodies for that, I thought, you know what? Something is right with this dude. But there was no African-American pulmonologist for me to go to. Okay, we know that we are not fairly or not represented in our community as we should be. So the end result is that what was precancerous, and a decision was made not to remove that part of the lung, turned into cancer. I want to share this with you because this is extremely important. My primary care physician is a Black woman that works at a very well-known hospital here in Chicago. Okay, but she's one of the few Black women that works in that hospital. In passing, she said to me, all he had to do was take it out. But I didn't really catch it on like that, right? So I thought, why am I going back to this guy? This is the second time. So I go to the Mayo Clinic in Rochester, Minnesota, and the pulmonologist says to me, all he had to do was take it out. But he had told me that there was no way he could do surgery on me, that I would be on oxygen for the rest of my life. I had limited stage at the time. Most people with small cell lung cancer do not get surgery. I did get surgery. I was told that I was curative. I went into remission for 5 months, and then it metastasized, meaning that it spread into other areas of my body. At this point, I didn't know what I was going to do. I'm still at that point today. Because no medication that has been given to me has worked thus far. going back to what you were saying, Reverend, I have lost many brothers and sisters because of lack of research that targets our population, okay? I felt lost, I felt alone. As I went through treatment, I faced some comments at times that, for example, I was referred to, and I think I'm a very nice person, I was referred to by the nurses as trouble, okay? What does that mean? I guess I'm an angry black woman too. Referred to as trouble. I didn't understand that. I would go to the cancer center and there were only 2 black nurses there. I went one day and the other black man said to me, he said, "Miss Payne, I really wanted to be your nurse today, but they told me no, right? I could not be your nurse." And I said, "Boy, that's because you black. Now go sit down. We don't worry about that, okay? Because we already know what's going on here."
But Ms. Payne, if you don't mind me interrupting for just,
That's okay.
I think there's some points here that I want to kind of carry through. One is that you were a smoker for a long time. Montessa was not. But you had a pulmonologist for 10 years,
Overseeing that.
and not once was it raised to you to have a lung cancer screening. And even when you had the x-ray done, that was done by your primary care doctor, and then you had this incident with your pulmonologist. And we have a similarity with Montessa's case where the x-ray for somebody with bronchitis, costochondritis, whatever it might have been, hadn't been ordered. So I think that that's an interesting kind of through line, that we're missing screenings, we're missing, simple tests that can be done to not only diagnose lung cancer, but even if it's something, like a pneumonia or something more common. I think to that point though, Montessa, I'm wondering, now that you look back over time, since 2006 that you had your diagnosis, what would you share with the audience? Like, what would you do differently knowing what you know now?
Yeah, so going back what I know now, I would have asked that they gave me an x-ray. As soon as they said I had bronchitis, had no idea, you trust physicians when you go in. Just like somebody explained it to me along this journey. If I come and I sit in this chair, I'm trusting that it's gonna hold me up. And so that I'm trusting these, that the diagnosis is correct. I wasn't a sick person, didn't go to the doctor as often. And I can tell you that we have advocated to get CT screening as a way to pre-screen for lung cancer, just like you have PSA checks for prostate cancer, you have mammograms. So we have fought long and hard. And, it's just disturbing that people still aren't telling you if you meet XY criteria that you should get a screening. The Today Show missed, that. So that's where I am now, seeing this journey along the way.
Yeah. I think the other important thing that I just want to put a pin in from Ms. Payne's story is that her doctor told her that we'll wait 3 months and recheck things. And I really want the audience to remember that, because when Dr. Flanau comes up and talks about doubling time, that's going to be really, really important to remember. So, but Ms. Payne, just to come back to what you were saying, you have obviously experienced a lot of, possible discrimination, even, certainly challenges through your diagnostic journey when it comes to your small cell lung cancer. Same type of question that I just asked Montessa, what would you, with the audience here today, who may have encountered similar, issues with the healthcare system, what kind of encouragement or advice, what would you want them to take away from your story so that they can take that into their own experiences with the healthcare system?
First thing that I would say to you is never give up. Don't quit. Because we know that the person who has the last say is not male or female. That's the God that we serve. And that's what I believe. Secondly, the most important thing that you can do for yourself when you are not well is to self-advocate. Never walk into a doctor's appointment. Let them give you some information. You say okay, and you walk out. You think about what is happening with your body prior to that appointment. You make yourself a list. If you don't agree, do not be afraid to say, I do not agree, okay? You might be able to have a conversation with that physician where you can come to a conclusion that is going to be helpful for you, because all doctors are not the best doctors, okay? Just like all social workers like me are not the best social workers. Do not go in fear, because you don't see other African American doctors there. Don't say there's no hope for me, because there's still hope for you. I traveled all the way to Jacksonville. I traveled to Rochester. I'm getting ready to travel some other places, okay? Because I have experience with another illness where somebody told me there's no help for me, and they hung up the phone on me. I got on that phone and I called Mayo. I said, look, I got some good insurance. Can you take me, right?
Yeah.
They agreed to take me. So my message to you is to don't give up. Don't think that you can't do the same type of, it might not be the same type of research, but if you can read, then you can research it, okay? If you can comprehend and you can understand, then you can learn more about whatever you are faced with, okay? I will say to you, stand tall, hold your head up regardless of the situation. Know that it could be a way made out of what has been told you that there is no way. Today I sit here and I believe that the new medication that has been approved will be given to me. If I was an individual who did not advocate, an individual who gave up hope, an individual who did not believe in God, I would be at home right now in the bed. I'm here with you to ask you to please stand, not only for yourself, but others within your community. We have to do a better job.
Amen.
Couldn't have said it better myself. I think Miss Payne is looking to take my job as moderator here.
She's looking to take my job as preacher.
So I appreciate all three of you for sharing your stories, and I'm happy to turn it back over to Dr. Tutson to speak us into the next part of the program.
Let's give that another hand. That was great. Thank you much, Reverend Love, but especially Ms. Lee, Ms. Payne. Excellent, 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 excellent. Okay. Careful getting down there. Okay. You know, we have heard the story and the impact of small cell lung cancer has on real people. This is not an abstract concept we're talking about. These are real people who've shared their stories. Now let's learn a little bit about what this disease is, how we negotiate the process of being treated, and then what the future looks like for us down the road. Our first speaker is Dr. Eric Flanow. Dr. Flanow is an associate professor and vice chair of medicine at Morehouse School of Medicine and down in Atlanta, and he's also the chief and director of the Pulmonary and Critical Care Interventional Pulmonary Medicine at Grady Hospital. Today, he will speak to us about non-small cell lung cancer versus small cell lung cancer in Illinois, disparities, prevalence, screening, diagnosis, risk factors, and staging. And oh, by the way, Dr. Flanow is a cover boy, being voted the most outstanding physician in Atlanta. Give it up.
Just advance the next. Okay. I don't have to focus on this a whole lot. I'll just talk right through it if you can't see it very well so you understand what we're talking about. Next slide. But I want to do about what exactly is lung cancer. So when we look at this, when we look at the pictures here, you'll see that lung cancer, all it is the genes of a normal cell here something happens to it and makes it just start multiplying and growing out of control. The genetic code changes. Okay? It's nothing that's going to catch from somebody, right? It's not going to spread through the air. It's just something about your own cells that start changing and growing out of control. It's the same with breast cancer. It's the same with prostate cancer. It's across the board. And then when it grows out of control, it starts to overtake other parts of the body. It starts eating up a lot of nutrition. People start losing their energy, losing weight, and then it just continues on without being checked. Next slide. Okay. So when we talk about lung cancer, there are two major types. Now I'll tell you about some of us physicians. We're not really good about making things. So there's two types of the small cell, and then there's what we call the non-small cell. Next slide. Right next to it. Yeah. So when we talk about small cell, this cells and all the little blue dots on there, those are the little cells. So in a group, they're smaller. They grow very fast. This type of cancer is linked more as a causative agent as being smoking too. But it grows very fast, they multiply very fast, it spreads very fast. And so it kind of is the more aggressive type versus the other type, which is the non-small cell. Click. You can see that those cells, purple there, they're larger. It grows a little bit slower, but it's still the same scenario of growing to where it gets out of control. And then this is the whole process of cancer. These cells just start growing out of control and they take over things. The thing about it, this small cell is so aggressive in how fast it grows and how fast it spreads, that the primary treatment for cancer of surgery is rare unless you catch it early. So you're more dependent on radiation or chemotherapy or a combination thereof. If you catch the non-small cell early enough, you do have an opportunity for surgery. Next slide. Yep. When we think about cancer in general, yes, well, okay, what are the causes? And we know 95% or more of the causes for lung cancer are related to smoking. And especially in the case of especially in the case of small cell, it's higher linked to it. But there are other causes. The number 2 cause is radon. Now, radon is a breakdown product of uranium that's in the soils. Okay, it doesn't have a smell, it doesn't have a taste, it doesn't have a color, it doesn't have, it's not even really visible. But it comes up from the cells and it gets into people's houses and stuff. And so I know in Georgia, very specifically, if you go to buy a new house, it has to be radon tested because it's that prevalent there. So the EPA requires it's the nearest test you can get. Let me tell you something about Illinois. Okay. So the EPA has a level, it's 2, it's kind of at the edge, and if you hit the level of 4, then you're above what they recommend you should be, and something needs to be done about it. Here in Illinois, 33.5% of the tests for radon are above that level. Right? So when we start talking about the causes of lung cancer, smoking, yes, radon number 2, and then you hear young people that never smoke coming up with it. We need to think in our communities about what's going on around us. Is it the environment? Is there pollution? Is there asbestos exposure? Is there radon? Should we be getting this tested? Because there might be things that we're not understanding that are causing issues. Why do they get cancer? They don't smoke. They're really young. Okay? We need to think outside of that and start asking these questions. Next slide. So we look at the new cases in Illinois very specifically. Illinois has done great over the past few years. You see, they're starting to get dropped a little bit in terms of new lung cancer cases. They can do better. I know as we were driving through the city yesterday and coming out that you were going out to eat, I see a lot of smoke shops. And I see a lot more of these hookah shops coming up. As if things are going to get you guys going the wrong direction. Next slide. But specifically for the Black community, lung cancer is bad. I want to tell you how and why it's bad, especially in the Black community. Next slide. So when we talk about these differences with races and lung cancer, and we're talking about the disparities that are available, a lot of times when you start saying this, the first thing that comes to people's mind is race, right? It's racism. Different. Yeah, sometimes maybe a little bit, but it's a combination of things that deal with our health and our health care. And when I talk about our health, we start talking about things like our environmental exposure, our diets, whether we're smoking, whether we're exercising, what's being invested, and there are biology. Because I'll tell you that lung cancer is more prevalent in African Americans, even though they may smoke the same as other races, and I'll show you that. And then it's healthcare. And what's available? Are there opportunities for early diagnosis? Are there opportunities for getting the diagnosis confirmed in a timely fashion? And there are the opportunities for treatments and the newer therapies that you were speaking about being available. Next slide. But what we do know very specifically for African Americans, they have the highest death rates despite smoking equally from lung cancer. They're less likely to get screening. They're diagnosed at later stages, and that becomes because you're not getting the screening. And they're less likely to get any treatment at all. Next slide. So I'll talk a little bit about the smoking rates. Okay, so it'll get hard to see, but I will point out to you. So we have African Americans, whites, and then Native Americans and Alaskans. And this they're talking about the smoking, the cancer, the incidence of cancer rates in the U.S. And it's per how many people get diagnosed with cancer per 100,000. Right. And then on the same side, the same rates will break down. African Americans, whites, and Native Americans. And then the yellowish color is the smoking rates, 25% for men, 18% for women, and then for whites, men, 26, and 20 for women. Right? So these are about equal. But look at the cancer incidence rates in the United States. Right? Almost a 10-point difference there. Right. So this does tell you something, that there is something about the genetic codes with African Americans that make you more susceptible to the bad effects of tobacco and developing lung cancer than other races. So it's not just the race, right? There's a biology component that factors in it. And if you really want to point this out, look at the Alaskan, the Native Americans, especially the men. They're smoking twice as much, but their rate of developing lung cancer is almost half. Next slide. And it's going to be hard to see because that's in it for 5 study days, so we're going to thank you guys for being in here. But the important thing is, on the top level here, I'm showing here new cases that we expect to see of the different types of lung cancer, of different types of cancer in African Americans. And then on the bottom, we're looking to see which type of cancer we're killing more African Americans. So for men, at the top, about 41,000 new cases of prostate cancer is going to be number one this year versus 13,000 for lung cancer. But if you come down, let's do the next slide. Okay. So about 13,000. If we look to see what's killing people, look at it again. Okay. Lung cancer steps up. So even though you have 3 times as much prostate cancer, it's the lung cancer that's killing more African American men. Next one for women, it's breast cancer versus lung. Again, 3 times as much new cases of breast cancer. But breast cancer barely beats out, only by maybe 50 or 70 in terms of killing more women, African American women. So this again is telling you that there's something more about this that's killing more African Americans. Next slide. Okay. Part of it, I think, that we're not understanding when we start talking about smoking is what I've learned over the past years is when I ask people about smoking and how long you smoke and how much you smoke, I've learned that I need to ask, what do you smoke? Okay, next slide. Because there's some aspects of things that people don't understand. I know this is hard to see, but I want to give you a general understanding. Smoking, when you smoke, you get several thousand chemicals that are released out of the tobacco smoke, which are going to give you the causes of developing the lung cancer. It's the nicotine that's in it that keeps driving you back to keep doing it. Okay, so that's where the drive is. The nicotine is the addictive part. So nicotine for a new drug now, the FDA would have a problem because it is so addictive. It's one of the most addictive drugs that we have out there now. The only things really out to good is cocaine and morphine. So that's how addictive it is. But it's legalized. but they do regulate it in cigarettes. So an average cigarette has about 8 milligrams of nicotine in it. And so you know, comparatively to all the other stuff that you're inhaling, that's your baseline. Now we talk about the little black and mild cigars, right? And you see those, and I've had patients jump and say, oh yeah, I put down most 22 or 3 of those a day and stuff like that. Do you know that one of those has 100 milligrams? That's almost 12 cigarettes there. So it starts piling up. The bigger cigars, 200 milligrams, that's 25 cigarettes in there. So when they feel like they're cleaned out and not smoking as much, they're actually getting the same amount in terms of risk factors from that sample. And that's prevalent, and the companies know this because they market specifically. You know, you have the little vapes and whatever else, they're putting the bubble gum and flavors so they get the kids addicted early and then make them up. Why do you think these are called black and mild? Because the marketing is there. Next slide. The hookahs, we asked a lot of those when we were driving through. Yes or no, and Italian. I don't quite get it because people go around, they get in a group of 5 or 6, there'll be an hour session, they're passing this thing around, and somebody's mouth get on it, there's smoke everywhere, and stuff like that. And they're thinking about, they get an hour session, they think about 200 puffs per session, right? With all this side stream smoke and that stuff here, that's about, in 1 hour, one person's hitting about 100 cigarettes. That's 5 packs. And when you start getting that much nicotine in, that drives that addiction. Next slide. And then cannabis. And there's a lot of discussion, legalized, not legalized, well, because in the beginning we didn't have a whole lot of studies talking about whether or not it developed into lung cancer or not. But what we do know now is that heavy marijuana use has a 2-fold likelihood of that person developing lung cancer. Yeah, so it's heavy. That's like, if you use it 50 times in a lifetime. Like people that do 50 times on a week, right? And this is what's been accepted. This is where we need to start making changes in our community because we start understanding these risk factors, right? And we start to move these forward because what's now accepted should not be accepted. Next slide. So, only opportunity we have is to get screened and catch it early is to get screening. Next slide. So what we're talking about screening, we're talking about catching a cancer anytime. Is it breast, prostate, colon, before you have symptoms. It's the same with lung cancer. We know that by the time you have the cough, by the time you have this spot on your x-ray and it's been there and they give you all the antibiotics and it hasn't gone away, you develop shortness of breath, you're coughing up blood, you're losing a lot of weight. When patients have that, 3/4 of them have late-stage disease that's not curable. So the only way to get it cured is to catch it early. Next slide. And we do this by screening. So just in general, if we know, and don't worry about this, the screening is, if you get screened, when you have the risk factors, that you're more likely not to die from lung cancer, about 20 to 25% less likely. When we talk about screening, we're talking trying to find this little spot before it causes problems. And that's important. And give you some understanding about this. Your lung, the tissue of your lung has no nerve cells in the tissue of it. Your nerve cells are on the edge when you feel that costochondritis symptom, right? Or in the airways when you have that cough. But in the tissue, there's nothing there. So when it starts out small and starts growing, it grows unchecked until you have the symptoms. So that's why you need to start screening early, because it's upstate lives. Next slide. Okay. So who should be screened? The current criteria is that you're between the ages of 50 to 80 years old, and you smoked. And you smoked what we call 20-pack beers. And the way we do this little math, if you smoke 20 years, 1 pack a day, that's a 20-pack beer. Yeah. If you smoke 2 packs a day for 10 years, that's 20 packs. If you smoke that or above, you should be considered for screening, especially if you smoke any time within that past 15 years. Very important. Go get screened if you're a risk factor, or if you know somebody, take them to get screened because it saves lives. It's not a blame, it's not a shame. You're trying to keep that person alive. Next slide. Okay. Screening for Illinois, you're doing pretty good. you're barely by the average. It's about 5.6. The average for the nation is about 4.5 of those people that are known to be a risk factor. But with all of the smoking that we've seen here, there's more people that should be getting sprayed. We just need to get them there. Next slide, thanks. Okay. Because when you catch it early, you have a better opportunity of getting treatments. And you're looking at different groups. This is early, limited, so we're calling localized stage. And this is where it's kind of in the chest, but only on the lymph nodes, and it's where it's spread throughout the body. And what we're looking at here is the red is African Americans and the blue are whites. And what it's showing is that African Americans are less likely to have it diagnosed early and more likely to have it diagnosed in a late stage. Right, so you're already behind the 8 ball when it comes to treatment. That's fun. Good. So it does find give you opportunities for improving survival. If you find it early, absolutely. Next slide. Good. But here's where the challenge starts. This is very specifically for Illinois. If we look here, the dark blue, black is white, and this is African Americans. Okay, and then we'll get early diagnosis here. So let's click it. So African Americans are less likely to be diagnosed early. So you're already behind the 8 ball. Next slide. We're looking at this is treatment. Right. Diagnosis for curative treatment, getting surgery for curative treatment. African Americans are less likely to get curative surgery than whites are. Next slide. And more likely, this is the lack of any treatment at all. By the time they're diagnosed so late that there's no opportunity for treatment, they're more likely to fall into that category. And so to understand this, when we talk about the doubling, you've heard this. They said, oh, come back and look again in 3 months, again in 2 months. It's doubling time. So I talked about this. There's this important part of doubling time where this cancer cell divides, goes from 1 cell to 2 cells. 2 cells to 4 cells, 4 cells to 8 cells. That's how you double in time. Next slide. And the thing that we have to think about, especially for small cells, because remember I said it divides status, it spreads status. Right? So the time for it to go from one each side to another side. Say I have a P, it's a P size. Now it's 2 P sizes. Now it's 4 P sizes. Is, again, 30 days. Wow. So if you have something the size of a walnut that they found, and they say, come back in 3 months, now it's 2 walnuts, now it's 4 walnuts, now it's 8. That's how aggressive small cell cancer is. Next slide. And the thing about it is non-small cell, I got it backwards, we'll go for non-small cell, catching it early, you'll get the treatment. From that standpoint. I'm sorry, I got ahead of myself, but it's true. So non-small cell is 60 to 90 days, right? So this is where we are. Next slide. But for to get the treatment, which ideal treatment is surgery for non-small cell. If you look right here, this says white men, African American men, white men, African American women. This is where our problem is. African American men need to get that curative treatment. We need to get them. We don't want to hear if we cut it, it's going to spread. They're not going to get any calming, whatever else. We need to get with that treatment. Next slide. Good. So small cells. So the first one is non-small cell. That's 60 to 90 days to double. Small cell here. This is the 30 days, right? To go from there. This is why it's more. That's 1 month. 3 months, you have gone up to 8 times the size it was in the beginning. Next slide. Yes. Next slide. Okay, good. So this is the most aggressive. This is where when we get the diagnosis of small cell, we need to move forward and your follow-up needs to be there. It has 2 stages there. You have an extensive stage and a limited stage. Basically, limited stage is limited into the chest. Extensive, it's spread to other parts of the body. The things about this are that when you have extensive stage small cell lung cancer, your average time of survival, even with treatment, is about 6 to 12 months. Even with treatment, after 2 years of treatment, only 10% of them sort of get into remission or disease-free at 2 years. It is that aggressive. Next slide. Yes. Yeah. There are some opportunities for treatment. Chemotherapy and radiation therapy, like pretty much there's standard treatments from that. It's very dependent on the stage you're in. There are newer treatments. Telemetry is coming out, right? Which they learn to trigger your immune system that help fight some of the cancer. And there's new therapies starting to come out that's available, and they're through clinical trials. And this is where I think you've heard this earlier, we need to be more involved in some of these clinical trials. Next slide. Okay. The problem is, traditionally African Americans have not been involved in cancer trials. Okay. There's 83% of the cancer trials are conducted on people that are not African American, only 6% in African Americans, and in some studies it's less. That means that when treatments come out, we don't know what works and doesn't work for specific populations because we're not participating. And there's a lot of concerns about being involved in clinical trials in the past, but what we do now know is it's not sort of this placebo or experimenting on. It's very well regulated. And the benefits of being in these clinical trials, you might get exposed and have the opportunity to have newer treatments that they have, that they know are safe. We get an understanding of how different treatments, algorithms, studies, procedures work in our population. And at a minimum, you're going to get either the standard treatment or you're going to get the newer treatment. So you will get treatment. Next slide. So your take-home points. Next slide. I can't go anywhere without saying prevention. Okay. We know that about 6% of middle schoolers are using some sort of tobacco products. Okay. We cannot preach to our kids not to smoke if they see you doing it. Next slide. Lung cancer screening. I would keep these in mind if you know someone or yourself, 50 to 80 years old, you smoke at least a 20-pack beer history, and need history. Like you ask about it. If you're not, you ask about it. Next slide. And again, the clinical trials. Once again, there's the infant being part of clinical trials. So we got probably called board with so. That's it. Be it. Thank you.
Thank you very much, Dr. Flano. Always a very interesting thing to hear from you. There will be time for question and answers. If you have something that's burning and you can't wait, you can ask it now. But if you will, we're going to have a panel with all of our speakers are going to be have a chance to speak for us. So after the end of things. So if you can hold till then, that'd be great. Our next speaker is Ms. Michelle Monroe. Ms. Monroe is a nurse practitioner specializing in thoracic oncology at Northwestern Memorial Hospital, Robert H. Lowry Comprehensive Care Center here in Chicago. She will address hope in research, treatment advances, and small cell lung cancer trials. Are you ready now? No. Thank you very much, Ms. Monroe. Thank you, ma'am.
Thank you so much for having me today. That was really great from Dr. Flanow. He really, in a short period of minutes, explained lung cancer, specifically small cell, and screening and prevention and all that. So if patients come to us for a consult or they're already getting care with us, when we have available trials open, obviously we're very aware of do we think the patient at the time may qualify for a trial? So there's a screening process in guidelines. So we present it to the patient. They go through the process to see, will they be a candidate? Do they want to enroll in the trial? Okay, so my presentation is titled Hope in Research, Treatment Advances in Small Cell Lung Cancer. We don't really need to go over the risk factors and things like that because Dr. Flanow did a great job. But what I like to emphasize there is that if patients have better outcomes, if the patients are diagnosed at an earlier stage. So screening for yourself, for family members, if they have any history of smoking, is key. So this, if you can kind of see here, where we talked about the evolution of small cell treatments for lung cancer, the chemotherapy that we have been giving, we started giving it in the 1980s, and we really didn't have anything that had any breakthroughs, anything that changed standard of care treatment until 2019, which is a long time. And even in 2019, we added immunotherapy to the chemotherapy that we're already giving. It did extend survival, but not as much as we would have liked. The immunotherapy in non-small cell cancer patients kind of really pushed the needle further, but with small cell patients, we know that we needed to do better. So this year, 2024, is really the hope that there's going to be new small cell treatment options available, which we know through research is how this comes to play. Sure. Okay, so clinical trials, what is that? So it's a research study that tests new treatment and/or prevention methods to find out whether they are safe, effective, and possibly better than the current standard treatment. So it's better than what we are already doing. Next slide. So clinical trials, they have inclusion criteria and exclusion criteria. There's strict guidelines and protocols that the institutes have to follow. Patients can continue receiving the drug as long as the patient is responding to treatment and not have any significant side effects. If it is determined that the trial drug is dangerous or not effective, the trial will close. Patients get very close monitoring during the trial period, and patients can decide at any time to disenroll. So it's not a binding contract. If you decide you want to enroll, and then after the first treatment, you're saying, this is not for me. Nothing is saying that you have to have a certain number of treatments. A lot of the trials, the trial drug can only be given at the academic institutions where the trial is open. So participation in a clinical trial, we want patients to explore all options for enrollment in clinical trials. So there's different phases of trials. There's also different times that patients can be eligible for our trials. So there's screening trials, there's prevention trials, there's diagnosis trials. Whether you're diagnosed early stage or late stage disease. And the other take-home key part to this is if you're facing a cancer diagnosis, we want patients, family members, friends, you want them to encourage them to get a second opinion at an academic institution. So a lot of patients that we enroll in trial, if you maybe are in a smaller town or your local hospital, you get your diagnosis and it says you have cancer, specifically lung cancer. They said, this is our standard of care treatment. Sometimes those practitioners are not versed in what's available because they don't have that clinical trial. They don't, clinical trials change all the time. Sometimes they close, sometimes they open, sometimes they stopped enrollment and then open a couple months later again. So getting that opinion at an academic institution opens your options, and then, then you can decide on the best treatment for yourself. So as Dr. Flanow kind of went into this more in depth, but we, encourage African Americans to join clinical trials. They do have, potential benefits for patients. You have available to treatment that's not otherwise available elsewhere. And we want to understand how the treatment is affecting this ethnicity population. We don't want to gather information on a drug that is, only in one ethnicity. And then, the treatment may be helpful or extend your life. That's our goal in a clinical trial. So there's steps before the drug becomes a clinical trial and it is tested among patients. So there's, scientists that are working on drug development in the labs, testing things on cell models, on animal models, and then there's different phases of a clinical trial for drug development. So phase 1 is an earlier phase trial, is when they're testing to see, what doses do we think may be safe and effective, and then they gather that data. They go on to phase 2, which we know that we want to see the doses that we had determined as safe. Are those doses, are they effective in treating the patient's cancer? Are we improving outcomes? But at the same time, we want to monitor their side effects and making sure that we're not causing more harm to the patient. Then phase 3 is when you have a larger population of patients in the trial, because we know that we feel that we have a dose that is safe. We feel that the drug is being effective in treating the patient's cancer, and we want to be able to gather that data so that they can be brought to the FDA for approval of treatment so that it could be offered to all patients. Oh, sorry. So phase 4 is if a drug is approved, they continue to gather data. So, just because a drug is approved doesn't mean that eventually we might say, hey, actually, in the 5-year run, we think that it may not be safe anymore. So they continue to gather data and outcomes and survival rates and side effects for patients, because also at that point you're giving drug to the whole population, and everyone's available to get it, so they're gathering more data there. So Amgen specifically has tarlatamab, which was talked about earlier. We had it in clinical trials at Northwestern. We had different phases of the trial. Like they were saying, it enhances the immune system to attack the cancer. It's kind of hard to see here, but it just shows that there's many trials that are currently open throughout the country. Maybe not all open at Northwestern or in the area, but there's a way that also your community doctor, or if they aren't aware of trials that they have at your institution, you can look up to see what trials are available and locations of them. And these are all different phases of different small cell trials using the tarlatamab in small cell lung cancer patients. So with the tarlatamab specifically, the early data was gathered, and in the trials, it showed that the tumor shrank in 40% of the people given a 10 milligram dose of their tarlatamab every 2 weeks, which is really great. We have a handful of patients on that dose in that drug. One in the early phase he's still on it, and it's been over 1.5 years. And then furthermore, in more than half of all patients whose tumors shrank with tarlatamab, the treatment kept the cancer at bay for at least 6 months, and in many, it did so for 9 months or longer. And then with all of that, amazing outcomes and data that they collected just recently, so 2 days ago, the FDA did approve granted acceleration for tarlatamab, which is amazing, for extensive stage small cell lung cancer. So this is treatment options after chemotherapy, immunotherapy. So we really feel that this is really going to kind of push the needle of especially extensive stage patients living longer with good quality of life. And this is just a little visual, research helps lead to FDA approval. So all drugs, no matter if it's blood pressure medication, diabetes medication, has to go through testing in order to get approved. But specific in lung cancer, the research has really grown, and we've, in the decade, so 2010, 2020s, all different approvals, whether it's pills, infusional medications, targeted therapy, we've gotten FDA approvals for lung cancer treatments. And through research, patients are living longer with better quality of life. And we continue to have hope that one day we will cure all patients who are diagnosed with lung cancer. Any questions?
Well, get something.
Oh,
Thank you very
yeah.
much, Ms. Monroe. Let's give another hand for Ms. Monroe. And that was one of the better explanations of a clinical trial, how it goes. So thank you very much for making that so clear. Our next speaker is different. No, I'm in trouble. Our next speaker is Ms. Ursula Mathis. Ms. Mathis is the Director of Quality, Comprehensive Programs and Services for the Phoebe Putney Memorial Hospital Oncology Service Line in Albany, Georgia. And if you don't mind, Ms. Mathis, I'm going to ask you just a couple questions that I was thinking about. Driving out here, I was rather impressed. Hope I got this one. Rather impressed with the traffic in Chicago. Best I can figure, they got 3 highways, of which maybe one will work, and everybody and their brother decides to take that one. And I gather that there is an alternative route which is unbeknownst to me, so I'm just sitting there. So I think that that's analogous to the cancer patient, at least some of the stories that I heard, thank you, from the stories that I heard where, you know, you're given this diagnosis and told, okay, I want you to go to Midway Airport. Oh, but it's 5:30 in the afternoon and 295 is blocked off. Good luck. Take me there, please.
Thanks, Dr. Tuxson. He's talking about navigation. So navigation is your GPS to your healthcare journey. And every patient, every cancer center, every program should have a navigation services or navigation platform or navigation win. And what the navigation does is just as he said, that if you start on your journey and you have to deviate from your route, the navigator gets you back on track. Should you need to see specialist doctors or should you need some additional testing, that navigator should be able to step in and to prevent you from having to make multiple phone calls, wait on calls to return to you, to be able to get those appointments for you so that your focus is on your healing, your treatment, and your cancer services, not on how you navigate the process or the politics of the care that's being provided.
That sounds good, real good. But Ms. Phillips already told us that you go to see your doc and your doctor tells you something and you want to get a second opinion. Now, I got to admit, there's not many people that I've heard will say, okay, I'm going to pick up the phone and call those people up in Rochester. How you bypass Cleveland, I don't know. But anyway, but you go up to Rochester. How comfortable is that discussion? And also one other thing. The other thing Ms. Phillips has is she has somebody with her. How important is that other set of ears and eyes?
Okay. So that is an uncomfortable conversation, but advocacy has to start with us. Navigation has to start with us. It's important that you do bring someone with you because we know that when you get any type of diagnosis, especially if it's a cancer diagnosis, after they've said what the diagnosis is, you've heard less than 5% of the remaining of the conversation. So having that support person there is a good person that can help you rewind that conversation once you get home or once you want to share with your other loved ones or your relatives. But we also have to be prepared ourselves for those conversations, for those physician visits, for prevention is important, screening is important. You have to be able to meet yourself where you are and know your status and know what your limitations are, what your comorbidities are. You have to be able to have upfront conversations that are detailed, factual, and inclusive with your providers, because if you can't be forthcoming with all the medicine that you're taking, if you can't be forthcoming with your history, then you are leaving them to play a guessing game. So we have to first start by navigating ourselves and being advocates for ourselves to write down your medications so that you can present them to your healthcare providers. Know your family histories. That can't be a secret in our families anymore. It can't be a secret that our parents and our grandparents had certain diagnoses and certain diseases or certain cancers. We have to know our family history because it matters on the precision of your treatment options.
We're in a big city, and it is assumed that everyone has access to transportation. But I've already alluded to how long it may take to go from one end of Chicago to another end of Chicago. Say I want to go to the University of Chicago, or I want to go down to Northwestern, downtown, and it takes me a while. What are obstacles to people completing their treatment, and how do you overcome these obstacles?
So with your healthcare journeys, nothing should be assumed, first of all, and you have to be very transparent about where you are. So it's on your visits to your physicians, you have to ask questions. You ask about and you discuss what your barriers to care are. We have a lot of patients that come in and, there's like, we have families. This is going to bankrupt my family. There's a financial barrier. They can't afford to stop working so they can get treatment. They're not understanding how their insurance is going to work or how things are going to kick in. But this is where your navigation and your social services should really kick in for you. They don't necessarily have to be called navigators, but these are services that most major cancer centers have that can provide assistance for all the barriers that we identified during your cancer treatment or your cancer journey. So transportation is a major barrier. Some households only have one car. If you have cancer treatment, sometimes radiation's every day. That's 2 people that would have to be out of work in order to get you to that treatment. So we discussed this barrier with our navigator, with our physicians, with our patient care team. And that's where we make a lot of mistakes too, because we feel like our access to care is through our physician only. There's a whole team that works around cancer treatment and works around most diagnoses that we have access to. So we access that care team to alleviate barriers, to dispel some of the myths, to create better treatment options. So transportation is a major barrier. Some patients have problems with housing. Some patients have financial problems and electricity problems, but you go through your social therapy, your social services, you go through your navigators, you do your distress monitors, but you're honest with yourself first, and then you're honest with your providers as to what your barriers to care are and what are your needs to treatment. When you are forthcoming, like a lot of patients are not, you'll be surprised how many patients have white coat syndromes and they mean to say a lot of things, and then when they leave they regret, and in hindsight they should have said XYZ. Not every patient is like our survivor here, but that's why you take notes. You come prepared. You write down what you want to say and who you want to say them to and the questions that you want to ask and the research that you've done. Any questions that you have, there's no bad questions. So any questions that you have, you should write those questions down so that you can leave with answer. Then you can go back and share them with your loved ones and your families, and you can make informed decisions about your healthcare journey. When you ask questions and you feel like that provider's not responding appropriately, or you feel like that provider doesn't have time to answer your questions, you ask for second opinions. You ask to see another provider. You research other options. It's not a one-stop shop, but it's not a one-stop remedy, because we have to be able to advocate for our care and our treatment.
Ms. Phillips alluded to it, and Ms. Lee probably had a similar experience, but they both had jobs that provided reasonable degree of insurance. Mm-hmm. Not everybody does, and we know that care can be expensive. So what about that individual that doesn't have, I guess, state or city insurance or teacher's insurance? So what do we do to try to help them so that they're not suddenly seen in a facility? And let's be honest, it does happen. Someone can be seen in a hospital. They'll do the fiscal biopsy on the wallet and find that they have coming up wanting they don't have quite the insurance that they want. And make no mistake, Mayo Clinic is not going to see somebody that has Medicaid. So what do we do? How do you help patients in that situation?
So this happens every day, and unfortunately, it's a real problem. But I always start back when I say that we have to be able to self-advocate and start with ourselves. So you can't present yourself in the emergency room or in your healthcare providers and you'll be uninsured, you haven't been to the doctor, you don't take what medications they did prescribe when you went to the doctor, you have been very negligent and non-compliant with your healthcare visits, but when you show up, all of a sudden it should be of importance and urgent to your healthcare providers. Because we see people, humans, who are biased, like we're biased. Everyone has unconscious biasness. Your urgency is not an emergency at that point to them. It should be, because we're healthcare providers and we've chose this profession because we want to see, but it's hard to treat a non-compliant patient.
Amen.
It's hard to treat a patient that's not informed about what is going on with them. Even if you're uninsured, you should know your family history. You should know what medications I'm taking, and I went to the urgent care and they gave me this. I went and I took this and I didn't take that. But to say you went and you stopped taking it, it was a blue pill, it was a yellow pill, I don't know what it was, I don't know what they said. We're not helping ourselves. And help has to start with you. Now there is also that patient that shows up that has just been neglected. The system has failed them. It happens every day, and it's unfortunate. But we're hopeful as we begin to educate the community, as we begin to educate our cancer centers and our staffs, and there are more people in place that look like the communities that they serve. They provide education and resources to physicians, to staff, to nurses, to patients, to the community, to everybody, so that we could come together to collaborate on how do we treat this population of patients. There are indigent funds out there. Every hospital, every system receives indigent funds to treat indigent people. It's federally mandated. For-profit, non-profit, every system receives indigent funds. There are clinical trials. We've talked a lot about clinical trials, but we haven't talked enough about clinical trials. And no, the medicines are not designed for us. And no, we know that research has been catered to other populations of people. But again, we've got to start with us. It's like that because we don't participate. Because we are going off history that we don't know the full story about. It did happen. We do own it. It is what it is. Like I said, it happens every day. There's some bias in health systems every day. But in order for us to get outcomes, we got to put in, bad out, good in, good out. So in order for us to get positive outcomes and all of us to have medicines that help our genes, medicine that help our people, that means that we have to participate in the clinical trials. Now, we still got to be careful about what trials we participate in, yes. I always tell my patients, if it's got this, just like any other scam, if it sounds too good to be true, leave it alone. If it's going to buy you a house, if you participate in this, don't participate. We have to stop participating for trinkets and start participating for outcomes that are going to better our people.
I'm gonna let you go. Don't go too far, because we're gonna have some more questions for you at the end. Okay. But thank you very much. I'm gonna give you another hand for that. I don't think I've ever heard that put that way. Don't go for trinkets. That was pretty good. Great. Our next speaker is Dr. Diana Gatto. She's a medical oncologist and clinical research medical director at Amgen. She will discuss what Amgen is doing with small cell lung cancer and what we can do. And by the way, I owe you an apology, Ms. Payne. I kept saying Phillips, and no, I should have gotten it right.
all of you for coming here today. I'm a physician. I've been working at Amgen for the last 5 years, and right now I'm the clinical medical director for one of the trials of tarlatamab for patients with small cell lung cancer. You know, at Amgen, we have a mission, a profound mission, that is to serve patients. And for us to accomplish that mission, we really need to understand your needs. Your needs and what you manifest will help us shape our decisions, to guide our actions, and also to inspire us to do better every day. We really have a strong relationship within the years with the healthcare system and the healthcare providers. We build a great relationship with doctors, nurses, nurse navigators, social workers. They share the challenges that you have. As Ursula was saying, they mentioned this to us, and we are trying to improve, to support you also with everything, you know. But we are here today to hear from you directly. We want to hear your expectations, your fears, your thoughts, your hope, okay? So approach us with concerns, with questions. We are here to support you. We are going to be at the booth right now. So come to us, help us with our mission to serve patients, express yourself. And this is the first time that we are coming to Chicago, but it's not going to be the last one. So we are here to support you. I just wanted to introduce me to yourself, and also to thank you all for coming here. Thank you.
I don't to join our panel. But
Yeah.
great. Thank you very much. Join me. He's Dr. Flano, Ms. Monroe, and Ms. Madden. She'll also come up here and join us. If you have a question, please raise your hand and I'll bring the microphone to you. But let me begin first off with, let's start with you, Ms. Monroe. Dr. Flano was telling us about the high mortality rate of African Americans with lung cancer, and you kind of touched on this also. Could you please comment on some of the other reasons that this could be? I mean, how much difference can there be between African Americans and whites? If you look in this room, there's a great variation between skin color. We go from light, almost white, to black, almost blue. So it can't be related to skin color. What are the things that you see that could be affected?
I think it could be some comorbidities. You know, if patients are getting diagnosed with extensive stage cancer in general, you know, if they have diabetes, if they have kidney function disorder, if they also have hypertension, obesity, patients tend to do a little more, or tend to not tolerate their treatment well. So, you know, the less comorbidities you have can play a role in getting your treatment.
So tell me, Ms. Mathis, so when you're talking to a patient and they're simply going, wait a minute, I didn't smoke, yet I'm coming down with this lung cancer. How do you talk to them about environmental factors when they say, okay, great, I'm gonna get treated, but I'm still gonna go back home and live next door to a factory that may be blowing air from Gary, Indiana. We'll pick one. Somebody from Gary, Indiana. Pick one day. So explain that to me.
So comorbidities is indeed a huge factor. Compliance adherence is another factor. Prevention and screening is our key to decreasing the rate of our mortalities with lung cancer. But then our environments do play a role. And when someone gets diagnosed with lung cancer, the last thing they want to think about is they got to go home and move. So how do we combat that? But it's education, it's knowledge, it's knowing, it's getting your home tested for the radon, it's trying to create an environment where the air that you breathe is a quality of air. It's smoking is a huge factor. Even if you don't smoke and someone in your home or in your environment smokes, the things and places that we go for leisure for is our casinos, clubs, restaurants, any place that we go where there's a smoking environment. Most restaurants you can't smoke in, but all our casinos, the things that we like to do for leisure and fun, we have to take all that in consideration when we're taking in consideration of our cancer journeys and our diagnosis and our lungs that we want to protect.
Dr. Gunter, you or Ms. Monroe, when you're looking at a person to enroll in a clinical trial, Ms. Mathis pointed out earlier that one inhibiting factor may be transportation. How much of that is taken into account when saying this person as an exclusion factor? I don't think that I've ever seen that written down. Do you have a car or anything? So how does that factor into a person being included to a trial?
Okay, so we have two different things here. First of all, when you have a protocol for the clinical trial, it is very strict on which is the population that can be included and which is the population that cannot be included. And this is only to have the better data available. You know, we need to standardize the data to have the better response and the better information available for physicians to take decisions. So when you don't meet those criteria, there is really little that we can do about that because we have to have the data really standardized, okay? But if you meet those inclusion criteria and exclusion criteria, and you have some kind of challenge regarding, for example, transportation or any other kind of expenses or costs or any other challenge that maybe are not logistical, lots of them are considered within the trial. So when we talk with the sites, for example, in this case, Northwestern, these are discussions that we usually have. We include in the contracts several topics that are going to be covered, and when they find a patient that fits perfectly for the trial, and maybe there is some challenge that has been identified, they contact us. They contact Amgen, we work it together, okay? It is our best intention to have that patient enrolled, to provide them with the best care treatment for them.
Ms. Monroe, how are you going to make sure I get down to the Northwestern? I ain't got a car. I'm not walking.
So we have social workers that help. And also there's stipends that patients can qualify for. So sometimes hotel rooms are, we can get the hotel room paid for by the study. We also have our own budget to help with patients' expenses if the trial doesn't or exceeds the trial what they cover. But we don't discriminate, and like if someone comes to us and they're 3 hours away, we're not gonna not offer it to them. We're gonna offer it to them, and if try to work around coming to us. And we do have patients that do come to us from really far.
Great. Thank you very much.
Thank you. So we know most patients, a large majority, especially in the minority communities, are treated in their community hospitals. And we've talked a lot about clinical trials, but we know that that community hospital might have a cancer center, but that the service delivery model and things are very different. How can we merge the connection between a community hospital and that research-based facility or a university healthcare system?
There you
Come
go.
take it.
Did you get first and then Ms. Monroe?
Okay.
Okay, Ms. Monroe, then Ms. Mathis.
Okay.
We're very forward.
I think that's a big, or an issue that we're having right now at Northwestern, and we do have committees and goals to get these trials open in our satellite places, but sometimes, the earlier phase trials, it's just really not feasible because there's so much involved in blood draws, EKGs, monitoring the patients, having specific staff that's well trained to know what to do in situations. And but it definitely those are our goals, and we try to get or are trying to get trials at Palos and CDH and Lake Forest and the ones that are opening. There's going to be a cancer center in Bronzeville. But if they're not able to physically get that trial drug there, even just taking the burden off some of the screenings or the CT scans, MRIs, the lab draws, the actual visits. So maybe, just lessening that load of coming down to downtown cancer center, is definitely helpful.
Let's get, sorry, Matt, let's go ahead.
So I want to answer that question for you because I work in a rural community hospital and we have a robust research program, but it hasn't always been like that. But it is important that the leadership of these cancer programs have a relationship with these academic centers so that they can collaborate. We have an institutional review board, which is our IRB. We collaborate with Augusta University so that we have access to all NCI trials. And Augusta's 5 hours away from us. But it took time to build that relationship. It took time to build that co-op. But there are opportunities for academic centers and larger community to partner with community hospitals so that these trials can get to the communities that are going to benefit for them the most.
Dr. Miller, I want you to address something for me, please. What is a reasonable expectation? I think inherent in Ms. Lee's question is, are we looking at a vertical integration or is this a lateral, horizontal thing when we're talking about care? So what is a reasonable expectation? You've just given me a diagnosis of cancer and I'm freaking out. Ms. Mathis has already told me that I probably will remember 5%. So therefore, I'm going to have my good buddy coming to the hospital with me so she can remember. But I'm freaking out. And you're going to tell me, yeah, come back in 30 days. That is totally unacceptable. So what should we expect?
Actually, yeah, that is unacceptable. And we realize, I don't think you're exaggerating, when I to tell about 180 people each year that they have lung cancer. And as soon as you utter those words, you can see the shift, yeah, big shift, they black out. They don't hear anything else you say after that because it's just such a harsh diagnosis, especially for people that are at the risk factor of the AIDS. One thing I always encourage, bring somebody with you, right? Just because they're also going to hear, right? They're going to hear that. But then we also have a time clock that starts ticking for us. Right? Especially, you heard earlier, if it's small cell, that is the most aggressive. In 30 days, you have twice as much cancer there. Right? So that time clock starts ticking. Our goal is to get treatment started within 30 days and less. That includes a lot of scans, getting back and forth to the hospital for blood work, testing, meeting with the oncologist, getting set up for the treatment, getting your access to have the treatment delivered, going. So I tell the patients at that meeting when I talk to them, I said, look, I know this is a hard diagnosis. It's not what you want to hear. It's not what I wake up every morning, I want to go tell somebody. But then I bring them back, especially a lot of the men, I got to bring them back. And I said, this is what we're going to do. I said, right now it's 2 o'clock, I'm clicking in, it's 2 o'clock. I said, I'm going to give you till 6 o'clock to go home and be sad and beat yourself up with that. And at 6:01, we've got to get moving. And so we have a handoff. We work with our navigators. We have the clinic appointments set up. We have their scans set up. We get the appointments. And if that they have an appointment with the radiation oncologist, with the oncologist, they need another test and whatever else, we try to make it to where those occur all in one visit. And you can ask for that. You can say, when I go to speak with the oncologist, not to drive all the way up here, and I have my appointment with the radiation oncologist at the same time. I get my scan earlier that morning. So you're not losing 3 days. You're getting everything done in 1 day. And that actually improves the timing out.
And I want also to address what Tessa was asking. There is something different that we are doing at Amgen for this specific situation. We know that a lot of population is within the community sites. We know that they might not be able to handle the clinical trial sometimes, not because they don't want it, it's because some logistic that the clinical trials require, maybe they don't have a staff. Some trials require some specifics like hospitalization, and they cannot work with that. So we are doing things differently. We have a lot of information that we provide to the physician. We have people like Liz here that is working in the medical affairs. She also shared information about the clinical trials that are open in academic sites to other community sites. So they can be aware that if they have a patient, they can refer it to these sites, you know. But another thing that we are trying to do different is this, is coming to the community. Information is power, you know. You have to have the most updated information that you can handle. The discussion with the physician is not your boss. The physician should be your partner in this journey. It's not a fight. You're not going to fight anybody. You have a journey ahead. You have to be partnered with them. Ask them. If you don't understand, re-ask them, okay? Ask them to explain it differently. As Dr. Flena was saying, you are the owners of your own path too, okay?
Thank you, Please.
This is for
Fleno.
Glenda. Okay, I heard you say something about radon being 33.5% part of lung cancer in Illinois, or something to that extent. I lived in DeKalb, Illinois for 1 year. At that time, before we moved to DeKalb, Alicia was screened prior. Well, not screened for lung cancer exactly, but she saw her pulmonologist regularly. Oh, she was screened. We moved to DeKalb. We had no idea about radon gases at all. 6 months prior is when she had the avalanche. She had stopped smoking before, prior to not having the, she was a smoker, but she had stopped.
Yeah.
And then all of a sudden this nodule comes up after we moved to DeKalb. And my mom was diagnosed 3 months after Alicia with bladder cancer, which was crazy. And I'm thinking like this radon gas is, would you say that radon played a part in this? And if so, should I go get tested for lung cancer as well?
So 2 parts of that. It's hard for me to sit here and say, but I would say it would be appropriate to have where you're living tested. Okay. So yeah, the 33% is of the people that actually follow through and get their living environment tested. 33% of those are above the EPA recommended levels for safety. They're above it, and it's unrecognized. The other thing to know about these risk factors, because radon is it's radioactive, right? So yeah, bladder cancer, kidney cancer, other things can develop. It's linked. But when I talk about smoking, when I talk about radon, when I talk about asbestos, it's not just additives, because there's some people that have been exposed to everything, especially a lot of our veterans that work in these burn pits and whatever else. It's multiplicative. So if I've had asbestos exposure and I've smoked, where one gives you 10% or 10 times the chance and the other gives you 6 times the chance to develop lung cancer, both of them together goes to 60%. So it's that effect. So when you see things that just don't make sense, this is where I live, and we moved here, and now this person had this cancer, and this other person had this cancer, and the person down the street had something. I would encourage you to get tested. Get it tested.
Let's address one other environmental factor, not external to the house, but inside the house. Could you tell us about secondhand and tertiary smoke and what impact that can have on us?
Yeah. So secondhand smoking, we do know that people that are exposed to secondhand smoking are at risk of developing lung cancer, and children asthma and other lung diseases. It's hard to quantitate exactly how much they're being exposed, but we know people that have been exposed and people who have been exposed, those who have been exposed have a higher risk of developing. Because, you know, the person's only inhaling a certain amount, and a lot of those other burned chemicals are being exposed, but the rest of it's being breathed out to where other people are being exposed to it. And that's why I don't get those hookah bars, right? It's passing this nasty thing around and smoking everywhere. I got people that won't share a straw, and then they're breathing some. Anyway, I'm sorry.
You're not making any friends at the hookah bars, and you definitely lost a lot of people with marijuana.
I'm sorry, I went on a tangent.
I mean, come on. You're taking away all the joys, man. We have a question for you, sir. Oh, sir.
Hi, I just wanted to ask a question about screening. Because when I was diagnosed, I was an asthma patient, but I never had a pulmonary doctor. I just had my, primary doctor, where I got my medicine and stuff from. So when I went in, I thought I was going in because my asthma had been off for a month. So I couldn't get the treatment going right. So I was a non-smoker. So when I went in, I'm thinking I'm just going because my machine is not working, and then I began to have a cough, and I didn't, other people was hearing it, and I really wasn't hearing it because I'm, babysitting. So then I just decided, let me go. And when I went, I was, in December, I went to the doctor and got a chest x-ray, and it came back nothing. In February, I went to urgent care, and it came back, you have we seeing something on your lungs. So I'm thinking, great. Now this explains, not even thinking of lung cancer. So when she came back and she said, well, it's not looking good, I said, well, it is good, because God got me, I'm good, So, but I never, to even explain to my family members, like, get screening. I'm still lost with screening because you get pap smears. You get mammograms, you get colonoscopies. I got all of those. And I never had family members with lung cancer. So I was really like, even my family was just like, never smoked in life like that. I never went to hookah bars. I didn't smoke hookah. I didn't do that. I didn't smoke. So it was really like taken back. So how do you get screening, or who's screening? I still don't get the screening part.
These are discussions I have with your primary care physicians, okay? And even though 95% of the lung cancers are related to smoking as a cause, you gotta figure there's another 5% that are not. And that's a significant number, right? Because 1 out of every 20 people may have never smoked, but are gonna develop lung cancer, because just having lungs gives you a risk factor for that. But like you said, something wasn't right with you. And you made the conscious decision that this is not right. I know my body, something's not right, and you follow up on it, and you went through and you had that discussion with your primary care physician. And I think that's an important thing, is recognizing when something's not right, you need to go in and get done. A lot of times people will put it off, especially when it deals with breathing. You find out, oh, I'm feeling a little more short of breath. People just stop doing as much and just kind of pushing it back. And this is where we need to advocate for ourselves. Something's not right with my body. I need to go get it checked out, see what happens.
Yes, Ms. Mathis.
I just want to echo that. That's exactly right. And when I say that we have to advocate for ourselves, you have to know your signs and your symptoms. In your case, it wasn't a screening test, it was a diagnostic. So you have to know that when you have your signs and your symptoms, to be able to express what's going on, how long this cough has been going on. I've had asthma X amount of years and it's never felt like this. This is different. And I can't get rid of it. This is chronic at this point. That's different from a screening exam. And a lot of people get caught up with, they don't meet screening criteria, but if you feel something is going on, that's no longer a screen. And it's the exact same test. It's how you word it in the verbiage and the codes they put behind it. So advocate for what you need and what you want. It does not feel right. This is not normal. I can't get rid of this cough. This has been going on X amount of time. Now I have shortness of breath. You got to keep the conversation going to be able to get what we want, because it's the exact same test as the screening test. It's just now because you have symptoms, it's called a diagnostic test.
How many people in this room either have asthma or have someone that lives with them that has asthma? Raise your hands high, raise them high. Thank you very much. That's a heck of a lot of people with asthma. And we know that in the African American community, there is a disproportionate incidence of asthma, which a lot of it has to be related to environmental pollutants. So can we assume, or should we suspect, that these individuals who have asthma have been exposed to something that could potentially be carcinogenic and should be screened for a cancer, even though it doesn't meet the criteria because they're not smokers?
It's hard for me to say from that because we don't have a lot of data on asthma's specific relationship to lung cancer.
But we do have a data on asthma and environmental pollutants.
Environmental pollutants, right. And if you have these pollutants, this is the time to go back to these exposures that you are aware of. That's the time to go back and sit with your primary care physician and see where the next steps are. Because even though you may not get the CT scan to screen, they can justify an X-ray as an initial starting point to look for something.
Thank you, Doc. I want you all to think about final comments, because I'm going to come back and ask each of you a minute what you want us to make sure we take home. But first, Nate, go ahead, sir. Oh, I got 3 questions out there. But see what you did, man? You stimulated everybody. There's a hand up here. Oh, everybody's pointing over there. Pointing over there. Yes, ma'am. I'm coming to you.
Hi. So my question relates to the clinical study. I see that you can do it for screening, prevention, and diagnosis, correct?
So there's all different clinical trials, but there might be a clinical trial right now that may look at detecting genetics in your blood to see, and then follow those patients. So they're collecting data. There could be one saying, let's do chest x-rays and keep following these patients. But obviously all these researchers and physicians and care team are trying to collect data so then they can present.
Okay.
And treat.
The reason I ask is because there's a propensity for lung diseases in my family. My grandfather died of emphysema. My grandmother, lung cancer that she didn't get diagnosed until she was 83. My mom was first diagnosed with non-small cell lung cancer in her 50s, and then small cell lung cancer in her 70s, and she did a clinical study at the University of Chicago with an expectation of 6 months to live, but she lived for 3 years, but she did all the treatments, chemotherapy, the combination chemotherapy, the radiation, and the immunotherapy until there was no response. So I have a new primary physician who recommended that I do the screening, which I did, and then I was called back by Rush Hospital to ask if I wanted to participate in a clinical study, simply because of the propensities in my family, the fact that I had smoked for 10 years and then quit for now 35 years. But because of the diagnoses in the family at later ages, that allowed me to possibly be a candidate to participate in the study. I was hesitant at first because the studies that they do and the scans that they do often use contrast. When they do the MRIs and contrast, it's not good for your kidneys, especially if your kidneys are not functioning at the maximum percentage. So today I applaud all of you and thank you, because it has given me the opportunity to learn more about the studies and why you do them and why it's so important to not only gather that data, but see also what's important to our community as a whole and our family and an individual in particular. So thank you.
Thank you. Thank you very much. Too bad you all not down here. You don't appreciate the full breadth of this young lady. The watch matches the dress, which matches the toenails. Just as clean. Please, go ahead. Who wants to take that question? Sorry.
So you made a lot of good points. It made it really easy for me. So a couple of things is when they talk about screening, all the institutions that have set up and have established screening programs, they are allowed to screen within a certain percentage outside of the recommendations for screening. So I gave you guys the recommendations earlier. These institutions are given a 10% variation from that. So they can screen some people up to about 10% outside of that before they use their accreditation. So how do they pick who they're gonna screen even though they don't meet the criteria? They need to know what those other risk factors that would push them to do that. I had a family member, this aunt, this uncle, this brother, this sister also had this disease. And that gives us, hey, there's a strong family history here. Maybe this person can qualify to get the screening outside of the criteria. So again, we go back to those conversations with your being open about your exposures, being open about your smoking and what you're smoking, or what you're exposed to from other people, or where you've worked in the past. It's not a blame, it's not a shame. The more information we have, the more we can help.
We have a question.
I've always wondered when they started with the diagnoses, and then they started evaluating the diagnoses with teams rather than just having a single doctor, and then the recommendations come out of the team. Is that a substitute for a second opinion?
I'm sorry.
In part. So this is what we call our tumor boards, our multidisciplinary tumor boards. So what she's talking about is when we know that somebody has a diagnosis, there's a group of us, like in our hospital, the pulmonologist is there, the radiologist, the pathologist, the oncologist, the radiation oncologist, the surgeon. We're all there to discuss all the cases that we've diagnosed within the past week or 2 weeks, depending on how they have it. And we go through everything, the pathology, treatment availabilities, the patient's factors that play a role into this. And we make sort of an informed decision on how to treat this patient specifically according to all the factors that play a role with them. And so this is our multidisciplinary tumor board. I say don't replace that. You can ask, has this been presented at the tumor board? And what were their recommendations? Because that's where you get all the experts that have been treating this in one room together, looking at the entire patient's information to make a decision. I'd much rather have somebody go through that tumor board discussion with the people that you're going to be seeing at the institution where you are, rather than the Facebook tumor board.
We're going to take one last question. I'm really glad to hear these questions because we actually do have lunch that's going to be here, and everyone is going to be here to sit down and you can talk to folks and get some more answers for any questions that you may have. That doesn't mean you're all off the hook for that last comment either. Yes, ma'am.
I'm just wondering, marijuana is legal in Chicago. I feel like I'm being exposed to it more now between my neighbor's backyard and driving next to a car where I feel like they're venting the smoke out of their car, out into the air. I mean, isn't that risk for exposure? Am I looking at that the same way you're looking at secondhand cigarette smoke?
Thank you.
I think in the long run, we'll probably start to see more of the risk of the secondhand exposure. Right now, it's such a new thing that we're seeing. It's hard to quantitate to say specifically how big that risk is. This whole legalization has just happened within the past decade or so. It's same thing with these electronic cigarettes, right? We're starting to see as time goes on and be able to quantitate it, what the risk factors will be. But it is something to pay attention to.
I'll tell you what we'll do. We'll give you Dr. Flano's phone number. So next time some of those people lighten up, you call and he's going to come and be the marijuana police for you. I promise you. He'll be right on the case. Ms. Monroe, what's the take-home point for us?
And I'm a big advocate of getting a second opinion at any point. So definitely at diagnosis. Even if you don't plan on going to that institution, it gives you confidence that if they say this is what we're going to start first, or if they have, you know, a newer treatment that they say we've had a lot of patients on this treatment, it's going to be FDA approved in a week or so. This is what I would want for you. I would wait, you know, till it's approved. Just getting that opinion. Then also too, if there's somewhere local in the area, you know, there could be a clinical trial that you can get before the standard of care. So you kind of hold that standard of care treatment in your back pocket while you enroll in a clinical trial. It could be first line, you know, to see if that would benefit you. And then if you progress or need new treatment, then also going to kind of do that all over again.
Ms. Mathis, your take-home point and call to action.
Self-advocacy is my take-home point, and we can't start advocating at diagnosis. We got to start way before that. Everyone needs a primary care physician. Everyone needs to know their healthcare status. Everyone needs to be in tune to their family histories, their comorbidities, what is going on with them. And then we also, as a people, have to lose some of our biases. Everything don't have to look like us to work with us and for us. Okay, so it does help when there are some things that you can identify with and things look like you, but we can't walk in the door with the assumption that we're going to be mistreated because the care doesn't look like us. There's a shortage nationwide of physicians and an even greater shortage nationwide of African American providers. So we can't not seek this help based on an assumption or what we heard from someone else's experience. Make it your own experience when you get there. If that does happen, be able to advocate for yourself that you want to go elsewhere, or be able to know the difference and be able to speak on what you need and what you want.
I want you all to realize, you know, we have the clinical research medical director of Amgen. You know, just think about this, Dr. Love. The person who's running a lot of programs has come here to us to provide some information. That's a heck of a commitment. And I gotta give you, Angela, I mean, just think about it. These are folks who are at the 10,000 foot level are coming down here